So now coming to fever and rash. So if a patient is coming with fever and rash, what are the approaches that you're going to do? First, you have to think in terms of certain conditions where you have to act urgently. So in that meningococcemia always comes first young chap, 20, 30 years, or maybe in the teens, presenting with rash, shock, altered mental status, headache. Always think in terms of meningococcal meningitis and infective endocarditis due to Staph aureus, Rocky Mountain spotted fever. In India, you don't have. I've seen a lot of patients who have a travel history to United States, especially Canada. I've seen a lot of cases of RMSF and sepsis. Of course, yes, it's a very urgent diagnosis. It can be due to from any source like pneumonia or UTI, and toxic shock syndrome where you'll have skin findings. And all these require rapid diagnosis and treatment because if you delay the treatment, patients might die. So what are the workup that you gonna do? So you're going to do the basic workup like CBC with differentials, basic metabolic panel, LFTs, LDH, creatine kinase, urinalysis, HIV, blood cultures and all those. And blood cultures always should be taken off antibiotics. Very basic workup. All right. Depending on the need again. So don't think like all these investigations will be required. Depending on what the patient's presentation is, I'm going to tailor the investigations accordingly. So, and then if the patient is I mean, you have to look at the rash course. So you have to look at the time course, you have to look at the morphology, and you have to look at like how they're looking. And one of the common rashes that we see in practice is erythema multiforme kind of a rash. I have a case later on for that, so which is going to present in the form of target lesions. And then we have erythema nodosum, which is very common in streptococcal infection, TB, sarcoidosis, Behçet disease. Anything can produce IBD, anything can produce erythema nodosum. And they are going to present with tender lower limb nodules, especially in the shin of the tibia. And even last week also I had a case, which is seropositive rheumatoid arthritis. That case presented with fever and nobody diagnosed her as rheumatoid arthritis. Everyone thought like it's just a diffuse joint pain, and her GP was treating with B complex tablets, and she came with fever. I can see the typical sign of it is joint pain, and she had erythema nodosum in her legs. We started with like short course steroids to treat the acute flare, and within like 5 days she got better. And we anyway started with Folitrax, that is methotrexate for her. That's different. But I mean, these are like very small, strong clues that there is some autoimmune process going on, like erythema nodosum. And it could be due to some infectious etiology like herpes simplex virus. It's going to cause that vesicular rash. And it could be due to mycoplasma, which can produce macular rash, syphilis, depending on the stage of syphilis. Primary syphilis, it can present with chancre. If it's secondary syphilis, it's going to present with macular lesions everywhere in the body, especially in the mucosal areas, palms and soles, and near the anus as well. And you're going to have varicella zoster virus, where it's going to present with chickenpox, Epstein-Barr virus, cytomegalovirus, adenovirus, streptococcus. Okay, tuberculosis can present with erythema nodosum, Bartonella, hepatitis B virus. All these things can present with rash during prodromal phase. So we have like plethora of infectious causes. I mean, again, I'm telling you, I mean, it's not like everything has to be ruled out at once. You have to keep in mind each and everything has to be differentiated based on how the patient is presenting. That's what is very, very important. That's why a good history and clinical examination, the travel history, the geography becomes so, so crucial in ID practice. In the first class, I have to keep emphasizing on that. History, exam, geographical history, travel history, where the patient is residing, and the sexual history of the patient. These are like pillars of ID. If you miss out on this and if you rely on antibiotics and tests, you will fail in diagnosing most of the time. And again, you will become a very ordinary GP treating everything with antibiotics, cephalosporins, cefixime, ofloxacin, and so on. So what are the non-infectious etiologies? So you have a lot of medications that can cause fever, as I said. So autoimmune causes are there, sarcoidosis there, IBD, Behçet. Pregnancy itself can produce a bit of fever. Oral contraceptive pills. You know that estrogen can produce like the palmar erythema. That's because of vasodilation. Likewise, estrogen can induce slight increase in body temperature also. That is why during that Mittelschmerz, there will ovulation time, there will be a small spike in body temperature. I mean, so you'd have studied in your undergraduation in obstetrics and gynecology. So pregnancy itself can produce a feverish state, but that's physiological. So immunosuppression, I told you, it's almost always means infections. So you have to find out what infection you're dealing with. That's a different thing altogether.